This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Break outside of the hospital box that you've been holding into. This ties back into compensation, maybe not just for our clinicians, but for our administrators. As we're thinking about an entire service line and focusing on those dual populations we've been speaking about, the plus 65 and then that at-risk younger population, you're going to have to think holistically, including outside of those four walls of the hospital.
Hello and welcome to Sg2 Perspectives. I'm your host, Tori Richie. Today, we are going to take a deep dive into the population impact factor and how that has affected the 2025 Impact of Change forecast. I am joined by two experts, Josh Aaker and Kate Zentner. Thank you so much for joining me today. Josh and Kate lead our cardiovascular and neurosciences service lines, respectively. If we think about the robust impact that changing demographics have on utilization for these service lines, these are great examples of where that silver tsunami is making landfall. Josh, Kate, I want to play back a clip from a previous IOC podcast from a few weeks back and just get your general reactions. And this should be a surprise to absolutely no one. The aging population is what's driving the growth, not only of population, what demographics are growing within the US, but where is demand growing across the care continuum. To a large degree, it's stemming from that aging patient population. Over 50% of inpatient discharges are going to stem from that 65 up cohort by the end of this decade. Josh, I'm going to start with you. How has this information driven your approach to thinking through forecast demand projections, but also how you work with health systems to prepare for this bolus of demand?
The best case example would be talking around structural heart. When patients have aortic stenosis, which increases with the aging of the population, the older Americans get, the more likely we're going to be able to find it. That's why we see this increase in demand. So there are likely two interventions. One is that open surgical, and the other is transcatheter valve replacement. Often this would be TAVR. And so if you look at our forecast, you will see that not only are we forecasting growth in the transcatheter valve procedures because of the aging of the population, and a slight decrease over time for those surgical valves. But diving into it, it's about the aging of the population and the acuity level. We're getting better at treating those patients with transcatheter valve replacement. Our average length of stay nationally is declining. We're getting better, even though the average age of those patients is often 80 years old. But when we look at the surgical, we're starting to see that average length of stay creep up because the only patients that are getting that surgery and the only patients remaining on the inpatient side are those older than average patients. Using age as a proxy for acuity, CV has long had an older than average population compared to other service lines. We've been having to deal with this. Maybe we're just not as yet formalized in making sure that we're segmenting out that geriatric population, not just at 65 plus. When you talk about CV, it's 85 plus. And I do think about the neurosciences also in dealing with that same type of patient cohort.
Yes, Josh, that's absolutely in line with what I would say. Neuro is interesting. It's a big mixed bag. We have populations that skew younger, like multiple sclerosis and headache. But when we think about the bulk of volumes, especially as you see in the inpatient setting and some others like home health, that 65 and up, with strokes, with dementia driving a lot of the volume. So inpatient, that's the big focus for a lot of health systems. We can see in most folks' baseline data the importance of stroke, same thing. Length of stay expected to rise a little bit with rising complexity. That piece is a lot what they're focused on. But at the same time, this is true for CHF. We are even seeing the age mix starting to shift a little bit, where those in a younger population, they're not going to become the majority. Certainly in stroke, it's still going to be the 65 and up, but there is this growing subset, that kind of 50 and under range that unfortunately is growing. This is a little bit of a different nuance that we talked about in our neurosciences webinar for the year, that as we are thinking about developing stroke programs, particularly what happens after discharge, we are going to have to think a little bit about that age stratification. Maybe put some specific resources in place for that younger cohort who are going to be in a very different life stage, have very different needs than somebody who is farther along, maybe 70, 80 plus, different than someone who's working. Maybe they're still raising kids and their demands are just going to be really different.
That's such a important perspective to bring to programmatic design. And it's something that we're in our infancy of developing and rolling out. Are there any organizations that either of you have spoken to recently that are starting to take that age stratified approach to programmatic design and care delivery?
It seems as though it's still in its infancy, partly because of where the bulk of volumes are. But University of Maryland actually does have a young stroke program that is meant to do structuring resources around that younger patient cohort. But we believe more folks are going to have to start doing it. And it's not just on the younger side, it's also going to be in that 65 and up. Tori, loved the example that you had shared in a webinar earlier this year talking about senior care stratification, whether it's age, whether it's stratifying, probably more so within that cohort based on different attributes. I think we're going to need to see a lot more segmentation probably than we have been within these populations, almost as the next wave of that ease-based care. It's sort of how can we sub-stratify even within that? Josh, I'd be curious for your thoughts too.
Yeah, not too many programs come to mind. There's a lot of programs that will focus on women's heart or, for example, their Latino population, depending on where they are in the country. But this is pretty nascent. And last year, I spoke about the majority of our heart failure patients are over the age of 65. All of the quality improvements that we had done in the past quarter century, the reduction of the mortality for CHF patients has gone away because of patients under the age of 45. There was a new study that rolled out looking at using risk stratifications for cardiovascular patients using PREVENT. And what was interesting was that overall, a lot of us have a low 10-year risk. There's a couple of us in those younger populations that have a really high 30-year risk. And so I was speaking with Chad Geese. He leads our clinical strategy practice. And he was pointing out those great bar charts that were shared in the IOC forecast that 65 and up, that's your today's patients. And those 18 to 64 are your tomorrow's patients. We're dealing with a capacity crunch today, at least from the CV perspective. I don't see that getting better anytime soon. We have to make sure that we have this high acuity, high resource space for older patients, but then make sure that we're connecting our younger patients as they start expressing these symptoms and these diseases, because we know they're going to likely progress. But does it need to be on campus? Does it need to be in a physical space? And those are the new questions we're asking, at least in CV. That's challenging because we're used to the 65 and up. Us getting on TikTok is not the same thing as, say, like ENT or OB-GYN even.
That makes me think about preparing for the patients of tomorrow. We also hear in different service lines about cardiometabolic, or in neuro, sometimes we're seeing brain health, where it's that same idea of how do we stem or thwart some of these issues upstream. That's going to mean targeting younger. I know for dementia, at least, we have not solved it. We still don't even understand what dementia is and what exactly causes it. But there is a pretty good sense that we're going to have to start intervening on patients quite a bit sooner. So it's that same thing about where do we start to capture them? And it's probably when they're a little bit younger.
An important element of that is if we work to set or prevent disease progression, we're then, from a resource allocation perspective, preserving resources for those where we're not able to prevent the advancement of certain conditions. It's also clear to me when I think about where all of the growth is stemming from if we look at demographic projections, it's in that older cohort. That's the cohort that is leaving the workforce. There isn't going to be the same number of humans that are able to provide care in the future that we have today. We're already incredibly capacity constrained. It's only going to worsen. And thinking about service lines where there is such high demand for heavily resource intensive services, have you started thinking through what are ways that we can, in addition to prevention and progression protocol, what are other ways that we can then help optimize care delivery to help meet that growing demand?
You were talking about the aging of the society. Yes, we are, according to the US Census Bureau, going from 1 in 5 Americans being over the age of 65 right now in 2050 to being 1 in 4. We've been talking about our patients, and we should always place the patients at the center of our conversations. But that also means that our clinicians are aging also. What are ways that we can use technology, training, starting to reach out into high school and start building stable pipelines for our workforce? It has to be an all-in approach. We are at or above capacity in many organizations, whether that's the ICU, the ED, the OR. Wait lists for some of our cardiovascular procedures are stretching into weeks and months. And unfortunately, patients die because of that wait. So this has to be an all-in approach. You mentioned cardiometabolic, and Kate, you were also talking about a lot of the team-based care clinics. And I think that's where we need to double down. If you look at cardiometabolic, those patients are here. Many of your CV patients already have diabetes. Many of your diabetes patients already have cardiovascular disease. It's not like you're finding new patients or needing to find new clinicians. It means coming together as a team and having appropriate conversations of where are we going to deliver care? Who is going to be doing that? And then what are the steps that we need to plan out ahead of time of, should this be talking to a dietitian? Should this patient be talking to a nurse practitioner, a PCP, a cardiologist? Or, for example, do we need to prep them for surgery? There's a whole spectrum, and us not talking about it is not going to expedite the solution anytime soon.
Josh, totally agree. For neurosciences, there really isn't a good way to sugarcoat this, especially for neurology. Access is bad. And especially as we look at things like patient lag times, it's actually pretty uniformly bad. There's not even a lot of variation in that interquartile range for wait times. They're all pretty consistently high. This tells us that if we're already in this position, it's imperative that we think about new care delivery models in order to do something different, because what we're doing now is not going to work if we're already in such a rough spot. One example I will give related to that idea of what kind of tools can we use to arm our workforce to hopefully lighten the load and enable a lot of that connectivity is with digital health. This was something that we talked about in our recent webinar as well. We've seen a couple solutions like this, both dementia, stroke, certainly other areas that this could be used for, as well as how do we use digital solutions to enable especially some of the navigation type services and all of the connectivity that we need in those in-between times for patients when we know we need to have quick answers for them. We know we need to probably be doing remote monitoring, all of those things. It's that personalized care that stays in touch with patients. If you do it the way we have been is so burdensome that our workforce can't do it. We've seen this especially in stroke. Transitional care works really well for patients if you can execute it, but almost nobody ever can. There are some solutions of this kind that help with that. And we see that when they're implemented, we can have really good results in terms of readmissions, in terms of patients adhering to the treatment plan that they need. But it's all about whether or not our health systems and different stakeholders in the healthcare space have the right incentives to implement these and prioritize that instead of the million other things that are burning that they could be doing. So that's the other piece. One of it is the tools. The other piece of it is the incentives for us to actually focus on this, knowing that there are so many different big rocks we're dealing with and different things that we could prioritize.
I love that. Alignment of incentives is something that health systems historically have not prioritized. And it's gotten us to this position of being overextended. If we think about some of the capacity constraints that organizations are feeling, throughput challenges that they might face. And I do feel like we're starting to make some inroads across some organizations. For example, Northwestern has done a ton of work recently in terms of aligning incentives and KPIs across the different business units to hold everybody accountable for length of stay improvement or throughput improvement or what have you. I know that that's challenging because in some instances you're messing with people's comp in order to make that a reality. But I don't know how we continue forward without making additional strides in that direction.
It's going to have to be different stakeholders. Like it can't just be health systems by themselves that are expected to do this. It's the payer partners, it's disruptors. It's going to have to be probably other folks that are involved in it as well. It's too much to expect providers to do on their own.
One way to help at least start solving that is to just go back to the service line model. This is important as we think about broadly the capacity challenges in, for example, the cardiovascular service line. I was talking about procedures, transcatheter valve procedures and surgical valves. So beds and inpatient stays and ICU utilization and cardiac surgeons and interventionalists. But you need to make sure that your medical cardiologists, your interventional cardiologists, your PCPs, everyone knows that, for example, putting our congestive heart failure patients on our quad therapy, the quad medical therapy or guideline-directed medical therapy, including SGLT2 inhibitors, helps to decrease the heart failure hospitalization by 22%. This is an all-in game. You need to make sure that you are helping make sure that congestive heart failure patients don't inappropriately get admitted to our inpatient service where they just sit and dialyze. So we can open up those beds for those procedures that patients are waiting on. They will go to other organizations because of that wait, or unfortunately, they may get sicker and pass away. You're connecting a lot of elements, and this is where the service line concept comes together. That way you can go to your payers as a service line. You can go to the administration. Maybe it's all about coordinating with imaging or labs or those handoffs that Kate was talking about. Presenting a unified voice of this is going to help everyone, even if it's indirectly to me. That, to me, is the power of a service line.
That approach allows an organization to more effectively achieve scale, which putting our patients first is the number one imperative. But give me an organization out there that hasn't been handed down a directive from their board that they need to grow. If that is the goal that they're working towards, deploying then strategies that are going to allow them to be effective in that is going to be critical.
Especially with service lines, the ones that are cohesive and they're acting as one living organism across the system, across the geography, those are going to be the ones who are better at figuring out even like the capacity challenge issue. We've seen this with a couple of systems across the country who have thought about that, and both in cardiovascular and neurosciences, the idea of portfolio approach and service distribution, all of that really critical. But the only organizations I've seen be able to do it are the ones who have strong service lines and the ones who have some organization, whether it's like a system level, a region level line, there has to be something to help them in that broader sense think about how to most effectively deploy their resources.
I'm very guilty of this. When I picture a service line, historically, it's been a very rigid structure. This is the service line. This is my problem. What falls outside of that is your problem. But what both of you are describing is a service line structure that is not nearly that rigid. It's more amoeba-like. It flows and it moves and it continues to change and evolve to ensure that you are providing those wraparound services and support to your patient population.
Break outside of the hospital box that you've been holding into. This ties back into compensation, maybe not just for our clinicians, but for our administrators. As we're thinking about an entire service line and maybe focusing on those dual populations we've been speaking about, the plus 65 and then that at-risk younger population, you're going to have to think holistically, including outside of those four walls of the hospital. We talked about being ambulatory first in some of our publications. Leverage those assets so you can use your inpatient assets for your more ill patients. It's likely going to be our plus 65 that are in there, but that means then your outside of the walls type of capital investiture or infrastructure. Again, we talked about the no-frastructure. That's going to be challenging for some of our legacy service lines. And I put CV as number one, and Kate is neuro number two in that.
Probably, yeah. Well, unless you count geriatrics, which we should, but that kind of permeates every single service line.
It's more of a programmatic offering.
We have a lot of overlap with that, definitely in neuro.
Kate, Josh, really appreciate you joining today and sharing your insights. When I think about how organizations can work through tending to the increasing demand, particularly that's stemming from our aging cohort, it all ties back to that old adage, an ounce of prevention is worth a pound of cure. And the insights that you shared today really underscore that perspective. Thank you for joining.
Thanks for having us.
Thank you.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.